going to start with this session with Dr. Seth Martin, who is cardiologist with the Division of Cardiology. He has a long-standing interest in preventive cardiology, and particularly cardiovascular risk assessment, and he has an interest in mobile health technology. So he's going to talk to us about that. Please welcome Dr. Martin.
Thank you for the kind introduction. Real pleasure to be invited. Good afternoon, everybody. Great to see this room here with a lot of interested folks in exercise. So I'm going to talk about the mobile health, digital health angle to this. How many people in this room have a smartphone? I'm expecting pretty much all hands to go up. How many people have a wearable on their wrist? How many people have an Apple Watch or Fitbit or one of those sorts of things? Okay. So, the origin of this dates back to when I was in fellowship and starting to think about how can we use new technology to promote exercise. Thinking as a cardiologist, sort of, it had become clear to me and multiple of my colleagues that we're just sort of frustrated over time. It's with that short visit you have in clinic, how much you can accomplish to really inspire people to be active. So how can we use these new tools? And around that time, some really innovative medical students came and spoke with our group about a new tool that they were developing, and that's what sort of started generating some of these ideas. So when I started as a cardiology fellow, these were the types of devices. In fact, I was given literally a device like this that I put on my waist the first week of cardiology fellowship that had our Chickaroni Center logo on it. And this is what we had. And it's, we've come a long way now to have all this really incredible assortment of devices. And it comes with advantages of reducing the friction of tracking physical activity and sending a real-time data stream. Then could, allows us to start thinking about how can this be leveraged to improve the physical activity habits of our patients. Was it just the device itself going to do it, or how can we tack onto this to really motivate our patients? When I started out in this field, I was told you can't use these devices for research. Are you silly? I mean, these are consumer devices. You need to use a research-grade device. You need to use the Actigraph. And I think we've come a long way where now it's very well accepted, even within NIH grant-funded research, to use Fitbits, to use Apple Watches as devices. And in fact, I've started to see some literature emerge showing that the Apple Watch is actually better than what were considered research-grade devices when it comes to the accuracy of measurements. So we're in a new world, and I was inspired to think, how can we use these devices? As a cardiologist, I think often in the framework of what does the American Heart Association say we should be doing, say we should be focusing on, but I don't need to convince this audience that physical activity, exercise is an important goal to have, but this is part of the 2020 strategic impact goals for the Heart Association. And what I like is that by focusing in on a behavior like physical activity, we can impact risk factors for cardiovascular disease. So what also inspired me is that we hadn't really made much of a difference in this for a long time. When I looked at data from NHANES, physical activity in terms of adults hitting the guidelines hadn't really changed in decades. Back to around the time that I was born, there hadn't been much change in physical activity. And some factors that would promote physical activity may have improved. Certainly the automation of work and having more desk jobs would lead to less physical activity, but this was inspiring. It was clear that new creative approaches are needed. This was reflected in a scientific statement led by Laura Burke at Pittsburgh on consumer use of mobile health and cardiovascular disease prevention. So she and colleagues wrote the amount of information that must be conveyed and the support that's necessary to counsel and motivate individuals to engage in behaviors to prevent cardiovascular disease are far beyond what can be accomplished in the context of face-to-face clinical consultations or through traditional channels such as patient education leaflets. So this is what I was saying earlier, that as a clinician, we have a limited amount of time. How can we fill that gap, really make an impact over the longer term on patients? They said that mobile health technologies have the potential to overcome these limitations, transform delivery of health-related messages, and ongoing interventions targeting behavior change. Yet we need evidence. And So that's what led me to do this clinical trial, the mActive trial, towards the end of my fellowship. And this was a randomized trial using an automated mHealth intervention. I'll talk more about that for physical activity. We hypothesized that this fully automated system with a tracking and a texting component to provide individual encouragement and foster feedback loops would increase physical activity. So here was the design of the study. We used a sequential design to assess the two components of the system, the tracking and the texting. So we started with a 1-week blinded run-in where all the folks wore the physical activity tracker. I'll show you more of that in a minute. These were patients from our cardiology center and randomized 2-to-1 to unblinded tracking versus blinded tracking. We first wanted to see how much does it matter, what is the impact of actually seeing the feedback of the step counts versus just wearing it and being part of the study. And then secondly, we then randomized those that were unblinded to get smart text messages. I'm going to tell you more about what I mean by smart text messages. So these were folks that, what I like about this study is that where many studies are sort of done in young, healthy people, these are real patients in our cardiology center. This is a group where really stands to benefit if we can develop a system like this that works. These are the folks who really could benefit. 18 to 69 years of age, they had a compatible smartphone for the device, and we excluded folks who are already using a tracker, who are already getting plenty of leisure time activity by the IPAC questionnaire, and that's what we were targeting was leisure time, or folks who were not able to engage in more physical activity. So the phase 1 of this study was that unblinding component that I mentioned. So the folks in this trial, and this looks a bit outdated, I would say at this point, the FitBug, this is what we use. I see Dr. Elizabeth Thrachford here in the audience, and she was one of the top enrollers into our study. And these patients from with peripheral arterial disease, with cardiovascular risk factors, with cardiovascular disease, were given this FitBug in the clinic. And as you see, it doesn't. The reason we chose this in collaboration with Ralph Passarella and the team of med students was that it doesn't have the number of steps on the device itself. So that's very unique and allows us to blind. So what we did was turn on, turn off, whether patients could see this screen here that actually shows the number of steps. Other nice thing about it was the battery lasted 6 months. We didn't need to worry about recharging the battery. So it would send by low energy Bluetooth to the smartphone, and the unblinded group could see this screen. The other group was not given access to the actual app to see. So they were tracking, but not actually able to see what how much they had done. The second part of the intervention was the smart text messaging. So this is smartphone delivered coaching. It was theory-based, physician-written, i.e. written by me, trying to incorporate clinical intuition as well as behavioral theories and leverage the therapeutic relationship by using the names of the clinicians in our trial. Everyone was a patient of a clinician in our Ciccarone Center. Texts were sent 3 times per day, customized to the patient's schedule. There were 2 types of messages, booster and positive reinforcement. So booster was if they were below their goal and needed a boost, and reinforcement was if they already hit their goal and we just want to try to close the habit loops by saying, look at how great you're doing, how you're feeling. It was very importantly, we didn't have to do anything. Once the patient got enrolled, the system ran fully automated. So we weren't sitting there typing text messages, having to expend energy from the clinical or research staff. It was personalized to 16 different factors. I'm not going to get into all of them, but for example, simple things like your name, but also who your favorite athlete is, if you had a dog and their name, spouse's name, things like that. And the goal, it was very goal-oriented to the classic goal of 10,000 steps per day. So here's just a very simple example. Jen giving someone a call tonight, consider walking while you talk. Dr. Martin's prescription is this number of steps. So trying to just use their name, give a practical tip, give a real-time prescription that's goal-oriented. Here's the primary outcome, change in directly measured accelerometer steps. And then secondary outcomes were the activity time as well as the aerobic time, which was walking continuously for more than 10 minutes without breaking, more than a minute. So randomization worked. There was no significant difference between the groups. So on average, it kind of looks like a typical cardiovascular population, 58 on average, almost an even split between men and women, 79% white, 44% dog owners, 73% married, 88% employed. Almost a third had established coronary heart disease, almost a quarter diabetes. There was only one smoker. We do a good job, especially by sending them to Dr. Ratchford to get people to quit smoking. Half with hypertension, 80% with dyslipidemia, and the majority were obese with BMIs over 30. So people got excited once they got into this trial, and so they got a lot of steps. And in fact, this sort of surprised me, and I learned from this. I didn't anticipate that when we chose people who are sedentary in their leisure time that are coming into cardiology clinic, that all of a sudden we put them into a trial, and now just by doing that virtually, on average, they're getting close to that 10,000 step per day goal at baseline. These people were very engaged. We had 97% data capture throughout the trial. So I think just by putting folks into a study, they were excited, engaged. We see, though, that aerobic time was disproportionately low at 11 to 18 minutes compared to total activity time. So this is mostly non-aerobic activity. So then what happened when we unblinded? So everyone was blinded. Now we have one group that can start seeing how many steps they're getting and then try to work towards their goal. How did that work? It didn't really have a significant effect. So the unblinded group went up on average 400 steps. The blind group went down 600 steps. It's a little bit of a difference, it seems, although not statistically significant, maybe if we had a larger study. In both groups, aerobic time was actually heading in the wrong direction from that baseline to the first couple weeks of follow-up. Things changed quite a bit once we started sending the text messages. So the group that got the text messages now all of a sudden went up 2,300 steps, or about a mile a day, versus the no text group that remained roughly steady, and the blinded group was just continuing to trend down, now 1,000 steps less in this second phase of the trial. So comparing the text to no text or text to blinded group, the results were highly statistically significant in terms of the difference in physical activity. And we see when we look at activity times that most of the change was in aerobic activity. 13 out of 21 minutes of increased activity time was aerobic time. So that was encouraging to see. So what about our goal that we had of 10,000 steps per day? Again, people are excited, and about half of people are getting that at baseline. Didn't really change by unblinding. But then once we started sending those text messages, now 81%, we doubled the amount of people that are hitting that 10,000 step per day goal by sending these automated text messages. So the interpretation from this trial is that automated tracking texting intervention increased physical activity with but not without the texting component. And this results support new tracking devices as facilitators in need of drivers of behavior change. And this is compatible with a perspective written in JAMA by Volp and colleagues from Penn as wearable devices as facilitators, not drivers of health behavior change. It's great to get a lot of data, but how are we going to translate those data into action? And we need those drivers, and I think sending messages 3 times a day is one way to do that. So what we learned in post-trial surveys and focus groups that we did after mActive, there was a lot of enthusiasm. We got a lot of positive feedback from the patients that were part of this, that we were on to something. They were not happy about messages that reminded them about their disease. So some of the messages reminded them about the effects of smoking or that they had hypertension. That was one of the variables in the algorithm, their personal risk factors. In general, people didn't enjoy being reminded of that during the day. They wanted more positive messages. That's something that we learned. They liked it being embedded within clinical practice, that this was part of their health providers, their clinician in the cardiovascular center were encouraging them to do this. And then they wanted the data to be coming back into the EHR, into Epic, and that's an area where there's still opportunity for improvement over time at Hopkins is integrating these wearables with Epic. And this was an early device. Frankly, the wearables are better these days than when we did this trial. We had, the Bluetooth energy didn't sync as well as it should, and these are things that have gotten better over time. So some people had serious frustrations with that, and we would get emails telling us about their frustrations with the syncing. But it was a minority of people, and in general, it worked pretty well. So my time's coming to a close in a couple minutes, but just wanted to say that I think some best practices here are the automation, because that allows for an intervention then to be scaled, which is the whole problem in the first place of us not having enough time to constantly counsel folks. Customizing it to really meet the needs of the individual. You need not just a device. We wouldn't, if we're trying to treat blood pressure, we wouldn't just give them a blood pressure monitor. We now need to build in the actions that are going to happen to reduce blood pressure, and same for physical activity. We need to help build in the actions to help increase it. Linking back to the hospital or clinic, I think it's best done as part of a health system like Hopkins rather than just consumer directed, and having an interdisciplinary team involved. So since then, we've had to, this original system we had, which was built by medical students, they went on with their company and pivoted and did other things, and we're no longer supporting this system. So we had to rebuild the system, and eventually we did. We got a grant with Vanderbilt where they're now applying the same approach within pulmonary arterial hypertension patients. So they've enrolled about 20 people so far. They're going for 75. We'll see how that goes eventually, and hopefully now that we have this new system, we can apply this more broadly. I hope we can also apply this, figure out systems to apply this over longer periods of time, which is really the key, is developing these habits that stick over a long period of time. So our new system is an integration of Fitbits through Fitabase, and then this system, Zapier, really links in the systems to the texting portion of things, but it's really functionally the same as what I described. So in conclusion, wearables are, I think, facilitators largely, not the drivers of change. We need to link new data to really help patients develop new insights and take those healthy actions that we are really encouraging. So the best practices: automation, customization, linking back to the hospital. There's great potential here, but for the clinical trenches really to resemble what's being talked about in Silicon Valley, there's going to need to be a whole lot more evidence and really figuring out how to build this into the processes of usual healthcare. But I really think this is a way, this type of approach is a way to enhance what we're doing in clinic, that counseling, and help take us with the patient after they leave the clinic, where they spend most of their time, which is out of the clinic. So thanks a lot for attention. I think we have a few minutes for questions.
10,000 steps is good even if you're not target heart range for a cardiac patient?
Yeah, it's a good point. I mean, that's a limitation of our trial, that we weren't looking at intensity of activity. We're really laser focused on step count. So I think you're right. This device that we used didn't have heart rate tracking. The newer devices do have heart rate tracking, so we have an interest in building that in to our studies, the intensity of activity, looking at the heart rate. There's the accuracy. I mean, Fitbit, the accuracy is okay. There's a lawsuit against their heart rate tracking, but other devices, it looks like, are a little more accurate, like Apple Watch. If you really want a good heart rate, you need the chest straps, which is what Under Armour had as part of their health box system, but that's not going to be around. So I think you make a good point. I would say that's a limitation of our study, and in the future I'd like to have more granularity about the intensity of activity in addition to just the overall step count. The reason we chose steps is because we could assess it with the device, and because it's just a simple metric with a simple goal that we could go for. Other comments, questions? Thanks again.
Great, thank you.